Okay, we're going to go over the concept of mobility and how it relates to fractures, joint replacements, and back problems. So just as a reminder, the concept of mobility just means how the musculoskeletal system works in conjunction with your circulatory system and your nervous system to allow you to move. So fracture is going to disturb this because it's a break in the continuity of the bone, so that appendage, wherever it is, cannot move in the way that it should. There's a lot of different types of fractures. In your Pearson book on page 915, it goes over a lot more of these. This is just kind of basic, this picture here. So a closed fracture means that it has not gone through the skin, so it's inside the body still, whereas an open fracture, the bone protrudes through the skin. A transverse fracture just means that it goes straight across. A spiral fracture is a twisting fracture. Most of the time when we see a spiral fracture, especially if it's in a vulnerable population like children or the disabled or even the elderly, it's from abuse because it's a twisting motion in two different directions. So it's hard to do that, just in your daily life. A comminuted fracture is a crush injury, so we have a lot of small bone fragments. Impacted means that there's been a lot of force exerted on one part of the bone to push it into the rest of the bone. The number one reason for that would be a motor vehicle accident. Green stick fracture kind of reminds me if you were to go out in the spring and try to snap a twig, and it kind of splinters, but it doesn't fully break, so it's just a little bit of a break. And then oblique is at an angle. And like I said, in your book, it goes over a lot more of these different types, so you can take a look at those. Our signs and symptoms would, of course, be pain. That's probably going to be the number one complaint. We'll see a lot of swelling at the site of the fracture, too. You may see some deformity, so you may see a shortening of the limb. That's pretty common with a hip fracture. Or the limb may be internally or externally rotated. There may be some numbness or blood loss. That could be if it's an open fracture, but it could also be in a closed fracture. You might have a lot of internal bleeding, so if that happens, you're going to see a lot of bruising to that area. And then crepitus is bone rubbing on bone. So you can feel crepitus. You can also hear it sometimes, so it kind of sounds like Rice Krispies popping. It's not the most pleasant sound. We make a diagnosis through x-ray. Pretty straightforward. Our treatment is always going to be immobilization. We want to immobilize that bone as soon as possible because it starts to heal right away. We do that through casts, splints, traction, or fixation. Okay, so casts are external. They could be made from a lot of different types of material. Oftentimes it's fiberglass. So there is a little chart in your book, in the Pearson book, on page 922, that tells you about cast care. Remember, we want to keep the cast dry. We want to put ice on it and elevate the area as much as possible to decrease swelling, because if it swells, there's really no place for it to go. And if there is any swelling or numbness, paresthesias below the site of the cast, if they're losing their pulse, if the skin becomes really cool, all those things are warning signs that they're not getting good circulation anymore. So that's when we need to call the physician, and we need to tell them that's when they would need to call the physician. Splints are removable, okay, so unlike a cast, which the patient can't remove themselves. Traction, there's several different types. This is probably the most common type you'll see in this picture. It's called Buck's traction, and that's what we'll do usually if somebody comes in with a hip fracture. We will put usually a boot on their foot and pull their leg straight to try to get it back into alignment, and then we'll hook up a system of weights and pulleys. So there's a couple of examples here, and there's going to be a weighted either magnets or a sandbag or something right here that's going to be pulling down and keeping this leg in alignment. So initially when we put this on, it's going to be very painful for the person. because we're pulling that bone back straight, but then hopefully it'll help some of the pain because it'll decrease muscle spasms. And we're probably going to keep them in that until they can go to surgery, okay, because bones start to heal right away and we don't want it to heal abnormally and cause a deformity or maybe even have to re-break it. So important things with this is we have to make sure that this weight never ever ever touches the floor, because if the weight is on the floor then it's not pulling the leg and then the bone can become displaced again. So that's very painful for the person. So always make sure that this is free hanging. They're probably going to need a fracture bedpan because obviously they can't get out of bed if they've had a fracture, right? Of their leg, and we don't want to put them on a bedside commode with a hip fracture. And we don't want to have a regular bedpan because those are kind of high. So fracture bedpan it is. And if you want to be a nice nurse, you'll make sure they have this trapeze so they can move themselves around a little bit in bed. This can be really uncomfortable after a while. So fixation can be internal or external. So external fixation would be pins going through the skin into the bone to hold something in place, but usually, especially if it's a hip fracture, we'll do an open reduction and internal fixation where we're putting rods and screws inside and then closing them back up. In order to get this limb back into alignment, we can do a couple of things. We can either do a closed reduction or an open reduction. And reduction just means putting the bone back into alignment. Closed reduction, we're just pulling the bone straight. Open reduction is when we're actually doing surgery and opening them up. Also, if you want to look at other types of traction, that's on page 923 in your Pearson book. So if a person does need to have an open reduction, internal fixation done, ORIF, that's probably the most common type of surgery you'll see for fractures. We just need to know pre-op they're going to be in a lot of pain, right? So we need to make sure we manage that pain. They may need antibiotics, especially if it's an open fracture, because it's a huge risk for infection. And if infection gets into the bone, it's very hard to treat, especially if they have underlying conditions like diabetes, for example. It may be impossible for us to treat. We're going to keep them NPO, make sure we teach them, what to expect post-op, that they're probably going to have a lot of pain, there's going to be a lot of rehabilitation afterwards. We're going to need to keep them immobilized pre-op, and then they may have traction. So it may be on the skin like a boot, or it may be skeletal with these pins and rods going through the skin. So this is an example of internal fixation where we've got pins and rods going through the bone. This right here is an example of an actual joint replacement. So we've sawed off the end of the femur bone and replaced it with a prosthetic. So post-op, there are a few things that we need to be aware of. We need to do all of the regular things that we do post-operatively, like teach them signs and symptoms of infection, monitor for signs and symptoms of infection ourselves, which of course could include increasing redness. I mean, there might be some erythema at the surgical site or the pin site, but if it's getting more and more red, that's concerning. Increasing pain, swelling, purulent drainage, fever, a lot of heat at the site. Those are all signs of infection and a lot of inflammation, so we need to keep an eye on that. We also need to think about bleeding. These types of surgeries, there's a lot of blood loss involved, especially if it's a replacement of a joint. Like if we have to take off the head of the femur, we can expect a lot of blood loss. So post-operatively, we really need to monitor that hemoglobin. It's pretty likely that they're going to need a transfusion at some point. We want to be careful moving them around. So typically, we don't get them out of bed the post-operatively, especially if it's a hip surgery. We need to wait for physical therapy to come in and assess them because we really don't want to run the risk of popping that hip out. We need to be very careful with their hips. We're doing something called hip precautions, okay? So we don't really ever want that hip to move at greater than a 90-degree angle. So when you think about that, when people are sitting down, they may need raised seats, raised toilet seats. They may need to move all of their clothing and supplies up to a high level so they're not bending down real low and popping that hip out. They should not be crossing their legs, or if they're sleeping on their side, they need to have something in between their legs, like an abduction pillow or just a pillow, so their one leg isn't falling over the other. And they really shouldn't turn their feet internally or externally too much, because that could pop that hip out too. And if that hip does pop out, they're going to need to go back to surgery. So we really don't want to be the one that's causing that to happen. So just think, if you're providing care for someone, you may need another person in there helping you to log roll them so that you're keeping those hips in good alignment. So there are a lot of complications other than just blood loss and infection. There's compartment syndrome, there's DVTs, and there's fat embolisms too. This is an example of compartment syndrome. We'll go over that one first. This is when you have a lot of swelling of the tissues in an enclosed space. So it's almost like an internal pressure ulcer. There's so much swelling, it starts to compress the tissue on itself, and it just causes the tissue to die. So that would cause severe pain, probably more than what we would expect the person to be in, and intensifying rather than getting better. They may complain of paresthesias or numbness, right? Tingling and numbness, almost like their limb fell asleep on that side. A feeling of fullness in that limb. And then possibly paralysis, where they can't even move it anymore. So that would be a late sign that's really concerning. This is considered an emergency. We may diagnose it through x-ray, but often it's pretty obvious what's happening. First thing we need to do is prepare for that cast to be removed. Okay, so that whatever is compressing, if there's anything there, then we need to remove it. If they don't have a cast and it's just their tissue that's so swollen, we may need to do a fasciotomy, which is this. We'll just cut, well, we won't. The surgeon will cut the skin open to relieve some of that pressure so that this tissue doesn't die. Okay, huge risk for infection now. So we're going to need to also give good pain management, because this is very painful. Our risk factors, if this isn't treated, is paralysis, okay, possible amputation, or a Volkmann contracture, which is where some of the tissue dies and it causes a deformity of that limb. So just know that this would be an emergency. So if you do have somebody with a cast, make sure that you're doing good assessments of the extremity. So like if they have a cast on their arm, you're looking at the color, you're checking the pulses, you're feeling the temperature of the skin, you're making sure they have good sensation, all of those things. Really good neuro assessment. So DVT is a deep vein thrombosis. This is usually in an extremity. It's a clot of some kind. It causes swelling and redness in that area, sometimes painful to touch. We would diagnose it through a venogram or an ultrasound. Our goal is to prevent this, so we want to make sure they're ambulating as soon as possible, with the help of physical therapy. We're putting TED stockings on. We may even give them anticoagulants, such as heparin, low molecular weight heparin, which is enoxaparin, or even warfarin. Those are our anticoagulants. We're encouraging fluids because we don't want the blood to be very viscous. If it's severe enough, they may have to surgically go and remove that clot. And then if it's not treated and that clot becomes dislodged, it can travel to the brain and cause a CVA, it can travel to the lungs and cause a PE, or it could travel to the heart and cause an MI.